record. So welcome, this is Stacy Chazen with Open. It's my pleasure to welcome you to the Action for Medicare Dental Learning Collaborative call for July of 2022. Our usual MC for these events, Melissa Burrows, is on vacation. So Bailey Rivas from Families USA is going to be stepping in. Bailey partners with Melissa on preparation for the calls usually, and has sometimes been a presenter as well. So we're happy to have her play that primary role today. I'll go over some quick housekeeping items as I mentioned, but for those of you who just joined, today's call is being recorded and we'll be sharing that on Open Communities afterward. Keep yourself on mute, please, until you're ready to speak so we avoid any background noise. And feel free to use the chat box for any conversation, for sharing resources as well. So that said, I'm going to turn things over to Bailey.
Hi, everyone. Hope everyone is having a lovely Wednesday. I know some of the folks here have been pretty keyed in on this effort. So definitely the more policy-minded folks on the call, jump in if there's anything that you want to add or that I get wrong. So essentially, there's been lots of movement on the biggest opportunity to expand Medicare oral health, which is in the medically necessary area. I know we've discussed it with folks, but just in case it's helpful, just a quick refresh. So currently you can get access to some oral health coverage in Medicare under a pretty narrow definition when you need oral health care in order to help, or to impact covered medical care in Medicare. So essentially if you need a procedure and in order for that procedure to be successful, you need to get some oral healthcare done that can be done in limited circumstances. So we've been pushing CMS over this past year to expand that definition to include more types of health conditions that will merit covering oral healthcare. And in the last month, we've had a lot of movement, both from Congress and from, most importantly, the administration on this. So we worked with Congress to get a letter. I know a lot of you folks helped reach out to your member of Congress to ask them to sign on. But we worked with Congress to send a letter from other members of Congress to CMS, essentially saying that Congress encourages them to take action on medically necessary, and had a lot of success. We had a letter from over 100 members of Congress. I think it was 22 senators, and then the difference between, and then like 87 House members or something. I'm sorry, I don't remember. I should have written down the actual numbers, but so really successful effort.
Ellie, I'm sorry to interrupt you. You're sharing such wonderful information, but can I ask you to slow down a bit? I think
yeah, of course. Sorry.
Thank you.
Thank you, Stacy. I was just going to put that in the chat. We're not, you're not going to get cut off, you know?
No problem.
Thank
Apologies. You get so used to talking at DC speeds. So we had this great letter from Congress that essentially was signed by 22 senators and I think 87 House members. So that was really exciting and just always good to continue to get members of Congress weighing in on these issues and paying attention to expanding and maximizing oral health coverage. And then 2 weeks ago, in really exciting news, the Department of Health and Human Services released their physician fee schedule for Medicare, which outlines, among many things, what Medicare will charge for medical services and, and related policies. And within the physician fee schedule, what is called, I think it's a proposed rulemaking, which means it's not final, it's not going into effect, but it's the administration saying it's what they would like to finalize. It included language to add additional oral health coverage in Medicare under this medically necessary definition for a few required medical procedures, and then there's opportunity to add additional medical procedures. It doesn't align 100% with what we had been asking them to open the definition to, but it's a huge win. It essentially is widening the definition of medically necessary in some really important ways. I know Wei is very keyed in on the nuances and the specifics if folks have questions on exactly what is and is not covered and what that means for folks accessing the care, but it's a really important win. And essentially what happens now is the administration asks folks to submit comments and say what ask folks to submit comments and say whether or not they support the rule, if there's ways that they can improve upon the rule, etc. So there's going to be an opportunity for all of us to submit comments by early September, and we can help give CMS advice on how to further strengthen the parameters and definitions for coverage, and essentially try and align what's in the physician fee schedule with the original parameters that we were asking them for coverage. So I think the first point is it's really exciting. So like, congrats to everyone. Really important advocacy over the last couple of years, I think, in elevating the oral health care issue to a point where the administration really had to make it a priority. And then obviously, I know there have been folks who have been working on this for many years. So really exciting. I think if folks are interested, I'd love to hear, let me pause and I'll open it up for questions.
So we have Marla posed a question in the chat. Which medical procedures were included?
Yeah, I don't know. Feel free to jump in, Wei Wei. I actually need sorry, I'm on my iPad today and I am just gonna have to put it up here.
Okay, sorry, I was muted. So bear in mind, this is a proposed rule. So, you know, we don't get anything until the final rule. So, but what they are proposing is to include as examples that they will actually put in their regulations and in their policy. They're proposing to include, for the moment, dental exams and necessary treatment before organ transplants, and also before cardiac valve replacements and valvuloplasty. So those are the examples that they want to add to examples. So that's not to say that they're saying, you know, those are the only new things that they're recognizing as being covered. What they've also stated in this proposed rule is that their contractors, you know, the regional Medicare contractors that process claims, that they're saying that, well, those you contractors, on a claim by claim basis, you could also, you know, approve additional coverage that falls within our new interpretation or clarification of what the coverage policy is. So what they want to, what they're proposing to codify as their new interpretation is that the policy will make payment available for certain dental services in circumstances where the services are not just primarily for the care, treatment, filling, removal, and replacement of teeth and supporting structures, but where the dental service is inextricably linked and substantially related to and integral to a primary covered procedure or service. So that's, I mean, it's a pretty strict standard. So, you know, contractors looking at that standard could find ways of saying it's not inextricably linked, you know, but they are telling contractors, you know, you have some discretion to, you know, apply this standard to and to people who really need medically related dental treatment. So another important thing about this proposed rule is that CMS is, you know, they are seeking a lot of input. They want to learn about more conditions, and they want to see compelling medical, you know, literature, you know, opinions about, you know, when dental treatment is just really absolutely crucial to medical procedures and services that Medicare is already covering. So they specifically said, you know, we want to explore the possibility of, you know, when dental might be important for before an orthopedic surgery, or in the context of, you know, cancer treatments, or, you know, immunosuppression, you know, people with autoimmune disorders who need, you know, have medications that suppress the immune system. They're interested in, they want to hear about, you know, diabetes too, although they're saying that, you know, it doesn't quite fit into this new definition, but they do want input. The other thing this proposed rule says is, you know, they are proposing to have a process whereby every year they'll, you know, consider new recommendations from people about, you know, conditions that should be covered. So, you know, they want input on that too. So I think it's really important that, you know, our network says, yes, have this, you know, process where we can keep adding to the examples that you will recognize on an annual basis, that you'll just keep adding more things as the, you know, evidence becomes stronger and stronger. And then I'm thinking if there's anything else. There's just so much in this rule. At some point we will probably send out some, you know, way to kind of condense all of the different things that they're asking for information about, so that you get a real sense of, you know, what you might want to chime in about to help them, you know, come up with the most, you know, I mean, they want this to work. My take from CMS is that, you know, they want to expand coverage, but they don't want to do it in a way that's going to like fail. So they need a lot of input, because, you know, dental is not where their head's been at forever. So they need a lot of input. Oh.
Thanks, Wei Wei. I know Judy has a question.
So with all due respect, and maybe somebody else who's been around way too long can help with this. Maybe we need to bring up the current language. My sense is that that the language was there, but it wasn't specific. And I spent years telling medical professionals how to try to justify having certain dental procedures done so that there could be open heart surgery, so that there could be a kidney transplant. So the types of things that when you started speaking, you identified. So am I hearing you correctly that the initial rule will now be very specific instead of being general about those things? Because the issue all these years was not that it couldn't be done, but that people didn't understand how to use what was there and how to find the dental providers who would do the surgery. That somebody with an active infection cannot safely have heart valve surgery and so on. Other than that, I think that's fine. And if it has to be incremental, that's the American way. And prevention will be the last thing that gets on the boat. I'm just a little cynical. Mary, stop that. She's laughing at me, Mary Backley.
I'm laughing with you, Judy. I've been there through it.
Yeah.
Well said.
You know, I think that's fine. And I absolutely agree that we need to be there. And if they still need information, they still need information. It seems redundant to me. It seems like we have been, it's sort of like getting off at the wrong exit to go over the George Washington Bridge and just going over the same access roads over and over and over again. So let's move it. And Gary's question is really, really good. Is there any opposition to this other than the money?
Well, Judy, let me answer your question before Gary's. So I agree with you. We've been arguing that they've always had the authority to cover it and it should be covered. The problem is that even when we were able to get a dentist or oral surgeon to provide the service and bill Medicare, it would get denied. And then if we appealed it and won, let's say we won once we got to an administrative law judge who like saw, yeah, of course this can be covered. This is not just dental, this is really medical. when we used to win at that level, the agency, Medicare, would then on its own motion get that overturned, which was just devastating. We'd fight to win it on, So what's really important here is that we have some statement, but then it's going to be published in the Federal Register, where the agency is actually saying, no, this is broader than what, it's like the agency is recognizing that it shouldn't be overturning these, the coverage when it gets covered in these kind of circumstances.
Yeah, they're just trying to save money, and dead people don't cost them much, right?
So yeah, I think this could be helpful, It's definitely a step forward and not back.
Hey, Judy, that was really cynical what you just said there.
What?
I think
What? Cynical? Come on.
I think it's also helpful from like a prioritization generally for HHS to be taking more of an active role in wanting to maximize Medicare coverage in other ways outside of like the traditional Medicare too, and medical care, and recognizing too that like I think it's also helpful in the messaging that oral health care is full body care, that like you can't get certain types of surgery without needing to also address oral health care, that we can't treat these systems as differently. So I think there are the nuances of the specific policies and how that impacts, but I think it's a really important step too in changing priorities and in recognizing oral health care as being really or medical care as being inclusive of oral health care, and that we can't treat these two things as separately. And I think to the question about opposition, we know that there are groups that traditionally are not in favor of expanding medical, or aren't always in favor of Medicare expanding coverage of oral health care. I think specifically dental groups often, or like dentist groups are often not as supportive. They have, they always raise concerns that it overloads the dentists and it creates complexities for dentists to provide care. So I think we can expect them to be responsive, which is why I think it's so important for this group to provide proactively positive comments about why the Centers for Medicare and Medicaid Services should continue down this path that they've outlined in the physician fee schedule, because we know there will be groups who will ask them to be more restrictive in their coverage. And so I think it's really important for us to come out and say that we support the direction that they're going in, and to provide feedback about how they could be even more helpful in those areas. For folks who maybe did administration related advocacy under the previous administration, it's definitely a different tone in regards to submitting comments. I don't know if folks did a lot of that. I wasn't as engaged in this group then, but essentially previously you wanted to submit a lot of comments to overwhelm them and to slow things down and to provide specific details in case there was litigation. And in this case, we want to provide comments to kind of overwhelm the negative comments. We want them to know that there is a lot of positive feedback about where they're going, and that there is a lot of support and momentum if they wanted to, change it in the ways that we think would be even more beneficial. So as Weiwei said, we're going to try and put together essentially a template that folks can take, and that way, since comment writing can be very technical and I think very time intensive for organizations and for folks that maybe don't engage in that day to day. So we're hoping to put together something that we can share with folks, so that way you all can provide comment to HHS and CMS on this.
Yeah, I think the optics of really being in opposition to this would be bad.
Yeah. Yeah.
But I think any opposition will be couched in, oh, this might not work very well because of X, Y, and Z, that kind of thing. So to the extent that positive commenters can provide, the opposite side of that, like, actually, this could work, because, for X, Y, Z reasons,
So
that would be helpful.
I just wanted to, I thank you very much for that answer, but I wanted to clarify at this point in time, there is no organized opposition that we know of. Is that correct?
I don't know that I wouldn't say that there's no organized, like I know that the ADA has frequently not been supportive in things like this. So I imagine that there is something on that end. I don't know, Wei Wei, do you know more specifics?
Well, I know that in the past, ADA has said that they do think that there should be coverage for dental in limited, specifically 4 different clinical scenarios. So I don't know that they would, that they still hold that position, but that was a prior position and it's out there. So I kind of think that at the very least, they're going to, maintain that they agree with coverage in those 4 scenarios, which are organ transplants, bisphosphonate therapy, head and neck cancer treatment, and also I think leukemia and multiple myeloma. I think I may have gotten that wrong, but.
So wait, and Bailey, so what I'm hearing from you, and I want to better understand how Oral Health Ohio can be helpful here, is, I did put in the chat about this clinical, clinical consensus with all of these medical organizations who have put it out there that oral health is important. Would it be helpful in Ohio to reach out to these organizations, let them know that this is up for comment, and a letter of support would be helpful? It seems to me like hearing from non-oral health providers that would be very impactful for them, talking about the oral health. So that's one thing. Is that helpful? If it would be helpful, is there some way we could get some help at the state level here about what that letter should say when we reach out to those component societies within the states? That would be one thing. The other thing is, I thought when you said the bad optics around not supporting this, it's remarkable to hear that the ADA would not support this in relationship to life-saving procedures. It's astounding to hear this, that they may push back on this. But that's
We
a whole
don't
other
know.
issue.
They might not. They might not.
Okay.
You
Yeah.
might have a better say that.
No,
Yeah,
they've
Chelsea,
been
do you want to
moving,
respond?
they've been
Hold on one
moving
sec.
towards more support for Medicare coverage. I just looked. One of the things that I do for ASTDD is monitor resolutions that come into the ADA's House of Delegates. And I just took a quick look through the ones from last fall. I didn't see it. I saw more adult Medicaid and some pediatrics, but I think the year before, it was a little awkward. Paul, I don't know if you remember any of these, but there's movement there. It's not as it's not as bad as it used to be. It's better. But there were concerns about the payer and some of the technical issues, but not the idea itself. But I couldn't find it real quickly.
So I want to just give a shout out to Paul for the very civilized electronic hand raising that he's done. And I'm going to come to you, Paul, in 1 minute. I wanted to just give Chelsea a chance to chime in.
Thank you. And sorry, I've missed bits and pieces of this, just juggling a couple of different meetings right now. But did want to comment and thank you, Wei Wei, for providing, and Bailey for all this background. So in case, and sorry if I'm repeating something that's already been shared, but the ADA is submitting comments. I, of course, cannot comment on the details. I will put a blanket note out there that overwhelmingly supportive is how it currently exists. it still has a lot of review to go under. So who knows what this will change, but while it's been in staff hands, overwhelmingly supportive. And as Judy mentioned, a lot where the rubber kind of meets the road is requesting clarification about some of the technicalities and how certain items in the proposed rule would actually play out and if the systems are in place for that. There's very, again, I hope I'm not sharing too much, and I don't know what form, how this could change in the weeks to come. But there is pretty much no, as it stands now, no hard opposition. And I hope I'm not divulging too much. I'll leave it at that. Thank you.
Thanks so much, Chelsea. It's good to hear.
Paul, go ahead.
Yeah, no, thank you. So, well, so I appreciate the conversation and information. So I was also on the policy NRT that Tanya just put something in the chat about, that also talked about this last week. And I'm wondering, Wei or Bailey or others, maybe to help clarify something about your suggestions for advocacy, because it seems to me there's a number of issues here. So let me just take just a minute to explain them, and just one little bit of background that in a former life, actually the first 20 years of my career, which turns out now to be a long time ago, I was very involved clinically as a dentist in hospital dentistry, and seeing a lot of people who were having heart transplants and liver transplants and organ transplants and all these other diseases. And this was an issue that I got very involved with. I was at one point president of the American Association of Hospital Dentists, and there was a bill introduced again 20, 30 years ago on medically necessary care, which never went anywhere. So it's great to see the issue coming up again. But so it seems to me that there's several issues here. And what I'm wondering about is the advocacy thrust. So the issues as I see them, one could be, you've already got the authority to do this, so please stop blocking, attempts to use the authority you already have, and be more liberal about your interpretations and just let it work. That could be one advocacy point of view. The second one could be to try to encourage broadening the definition of the medical conditions where this would be, quote, inextricably linked, because right now the general philosophy is it's really only about a dental infection, some infection in the mouth that is impairing the success of a medical procedure, the heart transplant, the liver transplant. It's not about smiling, chewing, talking, having a social life, being able to get a job. None of that stuff's on the table. It's only about the mouth as a source of infection is really underlying all of this. So the question is there any room for advocacy to try to be more liberal? Because diabetes was a good example where dental infections in the mouth do make a difference, but they're not an immediate threat to life. So they're not being considered qualifying. So it could be a general, just use the information you have, could be more around advocating for being more liberal about the kind of conditions that count. And the third thing could be about what kinds of dental treatment. So after the policy call Chelsea shared with me, the Federal Register, which I hadn't looked at before, and there is some mention in there about the possibility of fillings, root canals, other kinds of treatment, because to eliminate dental infection, the simplest and the cheapest thing to do is just extract the tooth. And so, often in my experience doing this kind of work back earlier in my career, that was often the solution, because there really wasn't coverage. People didn't have enough money to pay for things. So all three of those seem like they're possibilities for advocacy. Use the authority you have, broaden the kind of conditions that you're going to cover, or three, be more liberal about the kinds of dental treatment that you will allow to reduce infection. I'm wondering if you have thoughts about the way you were suggesting to frame advocacy, or what you think might be workable.
Well, I think that CMS is asking for input on exactly what, especially the last two that you mentioned, other scenarios, they want to hear about it in these comments. So they mentioned diabetes, they said they're open to looking at it, but they just need more input from the medical community, dental community. They need to understand it better. They need to know that, the science is there.
But that almost seems more like a request for, or that the thing to do would be more of a gathering of scientific data, writing a referenced, sort of paper that says these conditions and here's the evidence of that, rather than just, we want to encourage you to do more or do better. You have a sense of that?
Paul, I'm sorry to interrupt you, but Anna, it looks like you may have inadvertently shared your screen. And I'm not sure how I can, oh yeah, I can stop your screen sharing. Okay. I'm just gonna share for a second and then take you right back. Go ahead, keep talking.
Okay.
Anyway, wait, I was just asking that what you said a minute ago sounds like what would be useful is almost a scientific paper, gathering the evidence about various conditions and showing that they could also have importance in people's lives or the success of these medical procedures.
That's almost what I think they want. And I think they understand it's not, September 6th, which is when the comments are due. That's not a lot of time, which is why they also are proposing this process whereby, they'll continue to get recommendations, on a rolling basis. So, yeah, but I don't think they're going just by saying, oh, you should do more. I think because they, they're limited in their staff. It's almost, they want other people to do a lot of the legwork for them, and then they present it to their coverage people, to make determinations. But
And I would just add with commenting too, the nice thing is that folks should really feel the flexibility to provide a comment that makes sense for the constituency or knowledge that you have. Like, I think Families USA comment is going to vary from Center for Medicare Advocacy's comment, because ours is going to be probably, I haven't seen yours, so I don't, but, I imagine ours will be a little, probably less technical in some of the nuances, and at points a little bit more big picture about what this means for families and individuals. So yeah. I think if you have questions about like what you should provide comment on, I think part of the answer too is like, if that is an area of expertise, and as Wei said, like CMS is asking for further analysis in some areas, if that's an area of expertise that you can provide, then like you should include it.
Right. And to that point, I also want to say that, this administration, they are really focusing on health equity. So to the extent that you can provide any compelling information to them about how expanding this coverage is going to help people who in populations that in the past may have not have been able to access the medical treatment because they couldn't access the dental treatment. And, to the extent you can reinforce that, I think it'll really help move them ahead on this. So.
Bailey, will you remind everyone when comments are due?
Yeah, they're September 6th. It's usually by like 5 or 6 p.m. is when the portal closes, but I can get a definite date and link on that.
Okay, great.
They are definitely due September 6th. I can't remember it. Some of them, I've seen a couple where they've closed it earlier in the day, so I just want to double check the time.
I just wanted to throw one comment in here. I think exactly what you're talking about, good, hard science and backed up stuff. They're clearly asking for that, but there's also a politic around the bureaucracy kind of getting cover for making a change. And I think that's, not to be underestimated.
No, that's really important. Yeah, they need to be able to validate what they're doing. So, yeah.
Bailey, do you have any sense of the timing about the template that Families is working on, when folks could expect to see that?
I would love to give an update on that. However, with Melissa being on vacation, I have to wait for her to get back and to confirm whether and when that would be. I imagine ideally we'd love to get it to folks in the first couple weeks of August. So that way they have time to turn it around.
Great.
I think that's a safe date to give folks, but we'll definitely update once Melissa gets back from vacation.
Okay. And Tanya, is there room for anyone in this group who might want to get involved in working on the open letter? Are you looking for more contributors there? More?
Absolutely. I mean, we haven't really begun. And again, Tanya Dorf-Brunner with Oral Health Kansas. I'm one of the co-chairs of the policy NRT. we haven't started talking about exactly the process. Paul certainly already volunteered to be a part of it. If anybody else is interested, you know, we're not going to say no. So if you're interested, just let me know and we will get to work. Quite frankly, we're going to wait, I think, until we have some more info from families and from Weiwei until we, you know, we are not the experts. So we're going to depend on some network members and then customize those for open. It will be probably pretty high level and pretty, as Weiwei said, pretty not scientific. But I like the advice Bailey shared about focusing on health equity. But so with all that said, if you're interested in being a part of helping us put together some comments, yes, please reach out. Thank you. Put my email in the chat.
Are there any other questions as you're considering getting involved in this and ways that you can support the effort? Any other questions you have, either technical questions or strategic questions that perhaps either Bailey or Weiwei or other folks on this call might be able to answer?
Well, how are we organizing around medicine to give the evidence, the science? Or is there somebody leading that, reaching out to all these disciplines of medicine to support the science for this?
Yes, so, you know, when we had the community statement with all of the like medical specialty societies sign on to that. So we're going to reach out to all of those, you know, organizations and you know, associations of medical professionals that signed on and, you know, do outreach so they know about this proposed rule and they'll have the template for doing comments too.
Paul?
Yeah, I'm just wondering on that question, particularly the question of the science issue. There are plenty of people in this country who could put together the evidence. I mean, the evidence is there, it's in the literature. I don't personally have time to do a big literature search and do it, but there are people who have that information more at their fingertips. Not to put Chelsea on the spot, but I asked the other day, and I think I already know the answer, is that you're not in a position, Chelsea, to say anything about it specifically, but the ADA has a Council on Scientific Affairs, and in fact, they are supportive of this. They certainly have people on that council who could pull together the evidence. If they're not willing, able to do that, there are other people who could as well. So I think maybe, you know, there could be some kind of a call for people to put this together, people who, you know, run residency programs, have residents who need projects to do. There's just a lot of ways to get the evidence, but it would take some, you know, someone would have to spend, you know, days in the library doing this to put it together in a way that fits the situation. But the evidence is there in the literature for a much broader range of conditions that are impacted by oral infections than they're currently listing, and a much broader range of ways to solve the oral infections rather than just taking teeth out. So it would take someone who's got that kind of background and has the time, or can enlist a graduate student or a resident or somebody to help them do it. But I think it's doable. So I'm not sure exactly how to do that, but there's the American Association of Hospital Dentists, for example, has a lot of residency directors, and maybe a call to them to alert them of this and to see if someone is willing to step forward to lead a scientific review quickly to put things together. Those are all possibilities.
Would you say American Association of Hospital Dentists?
Dentists, and maybe I can connect with you separately and just give you the, I know the executive director and a number of the people who are, you know, the leaders in that organization right now.
Yeah. I mean, what about all of our partners at like Harvard School and?
Yeah, same. There are people there who are capable of doing this, whether they have the time and resources to do it right now, but they have the capacity to do it.
You might get a head start looking at some position papers. ASTDD has a couple. CDC has grants to several states for medical dental integration. So there might be some things via their webpage. There have been articles published within the last few years, which might just give you sort of a jump start on doing that kind of thing. But I think talking to the residency, and Chelsea raised her hand. So ADA through what? Through HPI probably?
Really, no, I don't think our work is necessarily a great resource in this sense, but, and sorry for those of you who are on the call on Friday and I'm repeating information, but I think a really key thing to keep in mind is that CMS is not requesting evidence on causal linkages here. So again, as Dr. Glassman has pointed out, the evidence is already there, and we can go to some resources, like there are good Cochrane reviews on this, on some of these conditions and potential oral linkages or manifestations, or so I think, it's, while it is a lot of work, I don't think, there's obviously no time to do any additional research in this way, but a lot of what could be included as evidence already exists, some of which is ADA, Council on Scientific Affairs reports that are, publicly available. So encourage, folks to turn to those two. And sorry, I want to mention one other thing that I'm not sure has been brought up, just as like a point of information. It's in the proposed rule as a very minor, maybe it has one mention, but about making outpatient providers eligible for payment. I will leave it at that, but I think it's an important thing to note in the proposed rule.
Okay. Yeah, Marla, I can find the posting from the Federal Register to pass along. That has the specific language.
Right. It'll be published on Friday. I think it'll come.
Oh, it hasn't been published yet?
No. Yeah. No.
Oh, interesting.
So
okay.
It'll be published in the Federal Register on Friday.
But it is already available. It's just
Available.
not officially in the register yet.
Mm-hmm. Right.
Okay.
I can send you the link, Bailey.
Yeah. Thanks. Sorry, I was just thinking about since the date for comments is based on when it's going to be published, did they just announce the date that they were going to publish it when they announced? Okay, got it. I was like, how do we know what date that it's due if it hasn't been published yet? Cool. Okay. Sorry. Also, apologies. My internet has been going really in and out. I do not know what's going on. So thanks, everyone. Okay, well, any further questions on this? I mean, I think this is a really helpful discussion, and I think we definitely will look forward to continuing to have it with all of you in the various other aspects of Open, and definitely can communicate. We will be in contact over the next couple of weeks with the template, and are happy if you have any one-on-one questions to be helpful. Okay, well, I don't know. Was there anything else, Stacy? I can't remember. Or was that the gist?
Yeah, we had some discussion questions, but we've really talked about them already in this conversation. So I think we're all good. So we'll stay in touch with folks when the template materials are available. Get in touch with Tanya. She posted her email address in the chat if you'd like to become involved in the effort to create an a letter from Open. And reach out to me if you have any other support needs that pop up around this.
All right. Thank you so much, everyone.
Bye-bye.